Welcome to the late-breaking clinical trial number 2 session entitled Innovation Boulevard. I am Dr. Andrea Russo from Cooper University Hospital in Camden, New Jersey, and look forward to hearing more about results of these studies using novel technology to treat arrhythmias. We will hear about left bundle branch pacing for cardiac resynchronization therapy in an international collaborative study. We will also hear more about longer-term results of non-invasive radioablation for treatment of recurrent ventricular tachycardia in a challenging cohort of patients with refractory ventricular arrhythmias. 2 of the studies that will be presented use pulse field ablation technology that may avoid collateral damage while being used to treat atrial fibrillation. One of the studies combines both pulse field energy and radiofrequency energy delivered through a novel lattice catheter, while the other uses pulse field ablation with another unique catheter technology for pulmonary vein isolation. And finally, we will hear about outcomes with the totally subcutaneous ICD in primary prevention patients with a low ejection fraction. I'm certain this will be an exciting session that highlights innovation in electrophysiology. Each presentation will be followed by Dove and Hawk commentators. I hope you enjoy the session.
Left bundle branch pacing for cardiac resynchronization therapy. Results from International Left Bundle Pacing Collaborative Study Group. These are our disclosures. Cardiac resynchronization therapy using biventricular pacing is an established treatment with non-response rates up to 30%. Left bundle branch pacing has been reported as a novel alternative option for cardiac resynchronization therapy. The aim of the study was to assess the feasibility and outcomes of left bundle branch pacing in CRT eligible patients in an international multi-center collaborative study. This was a retrospective observational study involving 4 US centers and 4 international centers. The inclusion criteria were cardiomyopathy with left ventricular ejection fraction less than 50% with indication for CRT therapy. Left bundle branch pacing lead was implanted using a Medtronic 3830 pacing lead and a C315 HIS or C304 HIS sheath. The technical details of left bundle branch pacing have been previously well described. Left bundle branch capture was confirmed by demonstration of a paced QRS morphology showing right bundle branch block pattern in addition to any one of the following criteria. In this example, patient with wide left bundle branch block, his bundle pacing at high output seems to correct the left bundle branch block. This transition shows during threshold testing from non-selective left bundle branch capture to selective left bundle branch capture. During both phases, there is a constant peak left ventricular activation time of 76 milliseconds. Note that QLV is decreased from 144 to 99 milliseconds with left bundle branch pacing. Here's another example with the transition from non-selective left bundle branch capture to selective left bundle branch capture in a patient with a wide left bundle branch block. During corrective HIS pacing, there is demonstration of left bundle branch potentials in this patient. By optimizing the AV delay, there is fusion of left bundle branch pacing with native conduction, resulting in further narrowing of QRS duration. Echocardiographic images of left bundle branch pacing lead in the septum is shown here in this view. Fluoroscopic view of the left bundle branch pacing lead in the septum is shown here, with contrast lining the right ventricular septum. The endpoints of the study were left bundle branch pacing implant success, pacing parameters, QRS duration as measured from stimulus to the QRS end, stimulus to peak LV activation time as a measure of left ventricular capture, Clinical response was defined as improvement in at least one functional class with no heart failure hospitalization during follow-up. Echocardiographic response was defined as an improvement in ejection fraction by at least 5% or more. Super response was defined as an increase in ejection fraction of greater than 20% or reaching up to 50% from a baseline of less than 35%. Left bundle branch pacing was attempted in 325 patients and successful in 277 patients. It was unsuccessful in 48 patients. Ischemic cardiomyopathy, dilated LV, and IVCD were associated with lower success rate of left bundle branch pacing was successful overall for 85% of the patients attempted. Mean left bundle branch pacing capture threshold was 0.6 volts at 0.5 milliseconds at baseline and remained stable during a mean follow-up of 6 months. There were 7 lead dislodgements, but no late LV perforation or thromboembolic complication. QRS duration decreased significantly from 152 milliseconds to 137 milliseconds with left bundle branch pacing. Functional class improved from 2.7 to 1.8. LV ejection fraction improved from 33% to 44%. The improvements were greater in patients with underlying left bundle branch block compared to non-left bundle branch block patients. Similarly, compared to patients with ischemic cardiomyopathy, there were greater improvements in patients with non-ischemic cardiomyopathy. Overall, clinical response rates were noted in 72% of the patients, and echocardiographic response with an improvement in ejection fraction of 5% or more was noted in 73% of the patients. Super response rate was seen in 31% of the patients studied. On univariate analysis, LV end diastolic diameter, baseline left bundle branch block, QRS duration at baseline, reduction in QRS duration during pacing, and peak LV activation times were predictive of VF improvement. On multivariate analysis, baseline left bundle branch block and LV diameter were independent predictors of echo response. This was a retrospective observational study with no comparison with biventricular pacing or his bundle pacing. Long-term lead performance and extraction risks of this lead need to be carefully studied. In conclusions, ladies and gentlemen, left bundle branch pacing is feasible, safe, and is an excellent alternative option for cardiac resynchronization therapy. Left bundle branch pacing provides remarkably low and stable pacing thresholds. Baseline left bundle branch block and LV end diastolic dimensions were predictive of echocardiographic response. And thank you very much. These were our participating centers.
Hi, I'm David Callans from the University of Pennsylvania, and I'm presenting the Dove commentary on this trial by Dr. Vijayaraman. Left bundle branch pacing for CRT was a multi-center retrospective observational study. They included 325 patients with standard indications for CRT. They evaluated implant success and clinical response over 6 months follow-up. 85% of patients had a successful implant with specific capture of the left bundle branch. Capture thresholds were low. The mean threshold was 0.6 volts at 0.5 milliseconds, and they remained stable over the observational period. However, there was LV lead dislodgement in 7 patients. 72% of patients had a clinical response, an improvement of 1 class or more in New York Heart Association heart failure class, and the absence of heart failure-related hospitalization. 73% had a positive echo response with a greater than or equal to 5-point increase in left ventricular ejection fraction. 31% had a super response, a greater than 20-point increase in LV ejection fraction, or normalization greater than 50% when the starting point was less than or equal to 35%. Predictors of positive response included a true left bundle branch block using strict electrocardiographic criterion, relatively preserved left ventricular and diastolic dimensions, and non-ischemic cardiomyopathies as opposed to ischemic. I think this was a very thoughtful, large observational study using experienced implanters. I think it clearly showed feasibility and short-term efficacy of this strategy. As the author stated, we await the last word as far as randomized clinical trials of left bundle branch pacing versus biventricular pacing for CRT applications. Thank you.
This is Usha Tedrow from Brigham and Women's Hospital in Boston, and I'm providing the commentary on left bundle branch pacing for cardiac resynchronization therapy. A little context to begin. Cardiac resynchronization therapy is established for treatment of heart failure with QRS prolongation, but this therapy is often limited by the anatomy of the coronary sinus and available sites for left ventricular pacing. His bundle pacing is an alternative to cardiac resynchronization with an LV lead, but depending on the site of conduction block, QRS narrowing may not be achieved. Left bundle branch pacing has the potential to recruit more distal diseased Purkinje fibers in myopathic hearts. Overall, 325 patients were enrolled. 44% had ischemic cardiomyopathy. There was an average left ventricular ejection fraction of 32% and NYHA class 2.7 heart failure. A successful implant was performed in 85% of the patients. There was overall a low complication rate with lead dislodgement seen in 7 patients. When looking at the patients that underwent an unsuccessful implant, the clinical characteristics were ischemic cardiomyopathy, larger left ventricular end diastolic dimension, longer QRS duration, and nonspecific IVCD. Overall, both the left bundle branch block and non-left bundle branch block patients showed improvement, but left bundle branch block alone was an independent predictor of improvement. Left ventricular end diastolic dimension was also a predictor of improvement. Looking at the 6-month outcomes, so a total N of 325 patients and 277 successful implants. It is reported that clinical response was seen in 150 of 207 patients. Echocardiographic response was seen in 148 of 202 patients, and super response was seen in 41 of 131 patients. It is not clear, however, why the denominator is different for the different outcomes and how exactly they were assessed. It is also unclear exactly which patient cohort was included in the reported multivariable model. To summarize, this is an important feasibility study of left bundle pacing in a group of patients appropriate for CRT. Implant success and acute lead performance are encouraging. A head-to-head trial against CRT would be needed to better compare outcomes, though single-arm assessment appears comparable. The authors are appropriately cautious about long-term lead performance and possible risks of lead extraction with long-term follow-up. Thank you very much.
Hello, my name is Philip Cuculich. On behalf of my colleagues from Washington University School of Medicine, I'm excited to share with you the longer-term results from a phase 1-2 study of EP-guided non-invasive cardiac radioablation for the treatment of ventricular tachycardia. These are my disclosures. Importantly, the results discussed here will involve off-label use of linear accelerators considered outside of their current 510K intended use. I want to thank our Data Safety Monitoring Board shown here, our funders, and our research study coordinator. This image shows a radiofrequency catheter heating tissue. Delivering a blade of thermal energy from the tip of a catheter is and always will be limited by the biophysical properties of heat transfer. And as a result, deeper VT circuits simply cannot be reached with a blade of heat. To deliver full thickness gap-free ablation, we can look to our radiation oncology partners who have the exact same goals when treating tumors. On the left is a stereotactic body radiotherapy plan for a lung tumor. Photons or X-rays are delivered in sweeping arcs with modulated doses or shapes to ultimately sculpt a volume that achieves high doses of ablative radiation within the tumor and rapid fall-off to the healthy tissues surrounding it. On the right, we simply asked our colleagues to shift the target, in this case to a basolateral LV location. There are several potential advantages to this method. First, the treatment is quick and entirely non-invasive. Second, the radiation is delivered across the entire thickness of the heart and not restricted by anatomy. Though this concept seems new, cardiac radioablation has been in development for over a decade. The first preclinical studies were published in Heart Rhythm in 2010 from the CyberHeart group. Doug Packer and his team from Mayo have expanded that to better understand various doses and tissue effects and different energies. The working biologic explanation is that the radiation induces an apoptotic programmed cell death early and then stimulates fibrosis later. The first in-man study was performed at Stanford in 2012 by Billy Liu, Paul Zai, and Amin El-Ahmad. Our group at Washington University published the first case series demonstrating a dramatic reduction in VT burden in 5 patients with refractory VT, and this finding was replicated in a larger series from colleagues in the Czech Republic led by Josef Kautzner and Jakob Svek. Based on these results, in 2017 we embarked on a formal prospective Phase 1, Phase 2 trial asking the following question. In patients with ventricular tachycardia who failed conventional therapies, can a single non-invasive radiation therapy treatment safely reduce the VT burden? In general, patients were included if they had sustained monomorphic VT or a PVC-mediated cardiomyopathy. They had to have failed at least one antiarrhythmic drug and one catheter ablation, and had a high burden of VT in the preceding 6 months. Patients were excluded if they had prior chest radiation, presence of an LVAD, use of an IV inotrope, or polymorphic VT. The primary safety endpoint was 90-day serious adverse events, and the primary efficacy endpoint was any reduction in VT burden, comparing the 6 months before and after treatment, allowing for a 6-week blanking period for anticipated biological treatment effect. A total of 19 patients were enrolled to expose the minimum number of patients required to assure safety while providing a minimum efficacy signal. The workflow can be broken up into the targeting phase on top and the treatment phase on bottom. In the targeting phase, we use electrical information, such as a 12-lead ECG or electrocardiographic imaging, during an induced VT during a non-invasive program stimulation. We combine that with the anatomic information from an MRI, CT, or viability scans to inform us of the potential target sites for VT. In brief, we use the exit site to identify the portion of the scar that we wish to target for ablation. Importantly, we do not always target the entire scar, nor do we perform invasive catheter mapping to guide our decisions. Once the arrhythmogenic scar is targeted, the patient then undergoes a treatment process which is nearly identical to SBRT for stage 1 lung cancer. This includes simulation, segmentation, planning, and delivery in a single session performed as an outpatient. The demographics and treatment data are shown here. Patients enrolled were balanced between ischemic and non-ischemic cardiomyopathies. They had a median LV ejection fraction of 25%. More than half presented with VT storm, and 3/4 had class 3 or 4 advanced heart failure. We targeted a median of 2 induced VTs for ablation, and after accounting for cardiac and respiratory motion, the median target volume treated for radioablation was 99 cc's. The median treatment time was 15 minutes. There were no acute events related to the patients or the defibrillators during the cardiac radioablation procedure. For the primary endpoint of 90-day safety, one serious adverse event that was probably or definitely related to cardiac radioablation was recorded. One patient developed pericarditis at day 80, which responded favorably to prednisone. One patient died 2 weeks after SBRT from an accident unrelated to treatment. After 90 days and out to 3 years and beyond, there were 3 serious adverse events that were probably or definitely related to cardiac radioablation. There were 2 pericardial effusions at 2.2 and 2.4 years respectively. These responded to oral colchicine. One patient had a gastropericardial fistula at 2.4 years, which required a surgical correction. Overall survival in this population was 89% at 6 months, 74% at 1 year, and 52% at 2 years. The cause of death was largely cardiac, attributed to heart failure and VT recurrence, with 3 non-cardiac deaths, none of which were related to treatment. Moving on to the efficacy endpoint, this waterfall plot demonstrates the VT burden of each patient in the 6 months before treatment on the left compared to the 6 months after treatment on the right. We observed a dramatic reduction in VT burden, with 17 of the 18 patients meeting the primary endpoint of reduction in any VT burden. We examined this further out to 2 years, broken down into 6-month time intervals. Keep in mind that it's 6 months of VT burden on the left and 2 years on the right. While freedom from VT was rare, 78% of patients continued to have less VT over a 24-month span following treatment. Shown differently, we can look at the median VT burden for each 6-month window of time. The median VT burden improved from 95 to 3 VT episodes in the first 6 months, and it remained low for each of the subsequent 6-month intervals that followed. A number of pre-specified secondary endpoints are shown here in graphical format. Nearly all patients had at least a 50% VT reduction. 2/3 of patients had at least a 95% VT reduction. 78% of patients had freedom from ICD shocks. 67% had freedom from VT storm. And 62% had freedom from the combined Vanish endpoint of freedom from death, shock, and storm. The study has a number of strengths and limitations. In particular, there was rigorous and complete clinical follow-up with no dropouts. There was vigilant and consistent endpoints with lenient ICD recorded events, and a broad, thorough evaluation for any adverse events. However, the study is limited by a small sample size, and there's inherent difficulty with risk attribution in a population so sick with advanced cardiomyopathy and competing comorbid illnesses. There is a survivor bias that we must recognize, which limits a more complete analysis of treatment benefits and risks. In conclusion, in patients with ventricular tachycardia who failed conventional therapies, a single non-invasive radiation therapy treatment safely reduced VT burden. The effect persisted for 2 years in most patients. And while serious toxicity was low, it may occur up to 2 years later, and long-term follow-up is needed. As such, cardiac radioablation is currently best suited for high-risk patients who have failed conventional VT treatments. Thank you for your time.
This is Dave Callans presenting the Dove commentary on the trial just presented by Dr. Cuculich. The longer-term follow-up of ENCORE-VT, which was a single-center phase 1 and 2 trial. The longer-term follow-up presented in this presentation is up to 2 years. 19 patients with advanced structural heart disease and ventricular arrhythmias that were refractory to conventional treatments, treated with image-guided radioablation in a single setting. Safety at 6 months was very favorable with just 1 episode of pericarditis that was treated non-invasively. At 24 months, there were 2 new pericardial effusions and 1 gastropericardial fistula that required operative repair. In terms of the safety, again, at 6 months, marked reduction in VT burden, with 94% of patients meeting the primary endpoint of a 50% reduction in burden or greater. At 24 months, this effect was maintained in many patients. There were still 78% that met that primary endpoint of 50% reduction in burden. The median burden remained low, but there were three patients who had accumulated more than 50 episodes over this period of time. I think ENCORE-VT represents a very courageous study of a promising strategy in a very difficult and challenging clinical situation for which we have limited effect with conventional therapy in all too many patients. As the authors suggest, continued vigilance and longer-term follow-up for the long-term effects, both in terms of efficacy and safety of radioablation, is warranted. Thank you.
This is Usha Tedrow from Brigham and Women's Hospital in Boston, and I'm providing the commentary on longer-term results from the ENCORE-VT study. First, a little context. Larger series of VT catheter ablation show long-term success rates in the 50 to 75% range. VT circuits in scar are often deeper than can be reached by catheter ablation. And in addition to fibrosis, other scar components can impair delivery of ablative energy into the tissue. Fat, calcium, and laminated thrombus can play a role as well. Development of novel strategies to deliver ablative energy to the heart is imperative. The ENCORE-VT trial provided longer-term clinical follow-up of their index clinical trial. They had excellent detailed patient follow-up, and the per-patient VT burden showed persistent reduction in episodes in the majority of patients. And this is despite a patient population that's a bit sicker than a typical catheter ablation series, with 21% reported as NYHA Class 4. Let's look for a moment at the late complications. They included 1 pericarditis at day 80, a pericardial effusion in 2 patients at 2.2 years and 2.4 years, and 1 gastropericardial fistula at 2.4 years. So what are the risk factors for gastrointestinal toxicity with radiation delivery? It's difficult to say with the number of patients studied here. The maximal dose of radiation delivered is the main determinant if you look at the oncologic literature. We cannot rule out that another patient factor such as extent of immune response may also play a role. To summarize, the longer-term follow-up of ENCORE-VT showed an impressive, persistent antiarrhythmic effect of radiation therapy. Some potentially significant complications emerged in late follow-up. Future investigation will surely include improving on existing methods for avoiding gastric and esophageal exposure to radiation during treatment. As the authors appropriately state, currently radiation therapy is most appropriate for high-risk patients who have failed conventional treatments. Thank you very much.
My name is Atul Verma, and on behalf of the PulsedAF investigators, it is my great pleasure to present this late-breaking clinical trial abstract on PulsedAF, first human experience and acute procedural outcomes using a novel pulse field ablation system. These are my disclosures, and I should also add that the Medtronic PFA system is investigational and not approved in the United States. These are the steering committee and investigators of the trial, and I want to give special recognition to Drs. Boersma, Hummel, and Willsmore, all of whom helped to recruit and treat these first patients. As you know, the burden of atrial fibrillation is increasing worldwide, and pulse field ablation, or PFA, is a bipolar, biphasic energy modality that enables lesion formation through the mechanism of irreversible electroporation. PFA has been studied clinically and in preclinical animal models, and I think the key to understand is that unlike RF or cryo, it is a non-thermal ablation, which may help to improve the safety profile. And what you see on this slide is the 9-polar catheter that is used to deliver the PFA that has both mapping and ablation capabilities. And above, you see a model of the electrical field produced by the catheter. So the PulsedAF trial is a multi-center, prospective, non-randomized clinical trial to evaluate the safety and efficacy of PFA for pulmonary vein isolation. And what you'll see here is that the primary safety objective is basically to assess the incidence of PFA system and procedure-related serious adverse events within the first 30 days after the ablation. And the primary effectiveness objective is to assess the acute procedural success of pulmonary vein isolation with PFA without using any non-PFA devices. If we look at the planned patient cohort, it is 20 patients. Patients may have either paroxysmal or persistent atrial fibrillation, which is symptomatic, but keep in mind that only PVI is allowed. Key exclusion criteria are long-standing persistent atrial fibrillation and a left atrial diameter greater than 50 millimeters. If we look at the patient characteristics, you'll notice immediately that I am reporting on only 14 patients instead of 20 patients. The last 6 ablation procedures were scheduled and ready to go, but unfortunately had to be deferred because of the COVID-19 pandemic. But you will see that the characteristics of these patients are very typical for an AF ablation trial with an age of about 64 years old, a left atrial diameter of about 37 millimeters, and a CHA2DS2-VASc score of about 2.4. If we look at the acute procedural efficacy, I'm proud to report that We had 100% success in all of the patients. So in other words, 100% of the pulmonary veins were acutely isolated, demonstrating exit and entrance block, and none of the PVs were isolated using a non-PFA device, and there were an average of 7.5 energy applications per vein. This is a video which is going to show the speed with which the electrograms can be reduced by PFA. So here you see the circular mapping catheter and you see pulmonary vein potentials. And as I play this video, you are going to see an artifact which occurs right now, which is the energy delivery, and you can see how rapidly those electrograms are eliminated. If we look at some key procedural characteristics, you'll see that the skin-to-skin procedure time looks long at 212 minutes, but keep in mind that this was measured from the time that the first sheath went in till the time that the last sheath came out. And in my lab, for example, the patient is first transferred out of the lab into the recovery area, and that's where the sheaths are removed. So all of that transfer time was included in this skin-to-skin time. I think the more relevant time is the left atrial dwell time of 90 minutes, showing how time efficient this procedure can be. And that includes a mandatory 20-minute waiting period after the last vein is isolated to check for reconnection. And we also spent a fair amount of time pacing to assess for exit block from the pulmonary veins. If you look at the fluoroscopy time, it was about 30 minutes. 5 of the patients required only conscious sedation, although the majority of patients were done under general anesthesia, but this was more because of local practice patterns. I will tell you that there is no skeletal muscle recruitment as a result of PFA ablation, so the patients are not twitching like they would during a cardioversion, and only 1 patient had any kind of neuromuscular blockade used. This is a typical voltage map of the patient, so you'll see that this is a wide antral pulmonary vein isolation procedure, but we are clearly not isolating the posterior wall or any other structures. If we look at serious adverse events, I'm proud to say that there were no PFA system and no PFA procedure-related serious adverse events. None of the patients showed symptoms of esophageal injury, and you can see here that the maximum esophageal temperature recorded was 36.1 degrees Celsius, and the change in esophageal temperature was less than 0.1 degrees Celsius, so this is a non-thermal ablation, and none of the patients showed any symptoms of phrenic nerve injury. So in summary, the pulse field ablation was used for PVI in a cohort of 14 patients. Acute isolation was demonstrated in 100% of the patients with no device or procedure-related serious adverse events. All of the patients will be followed to 12 months, and these results will precede a pivotal trial pending FDA approval. And finally, I would like to give special thanks to all of my co-investigators and the team at Medtronic led by Mark Stewart, who developed this fantastic new technology. Thank you very much.
This is Dave Callans delivering the Dove commentary on Dr. study, the PULSED AF trial. This was a multi-center prospective observational study of pulse field ablation for treatment of atrial fibrillation delivered via the Medtronic system. Pictures of the catheter, which has 9 poles both for recording and for delivery of energy, are shown to the right, as well as the field that is delivered by this catheter when pulsed energy is delivered. The investigators focused on acute safety, the absence of system or procedural severe adverse events, and acute efficacy, which was defined as PV isolation without the need for adjunctive ablation device. There were 14 patients with results reported of a planned 20. 93% had paroxysmal atrial fibrillation, and the left atrial dimensions were a mean of 36.7 millimeters. There were no system or procedural SAEs. There was 100% acute PVI with 7.4 plus or minus 3.5 applications per PV. The procedural time was 212 minutes, but this was largely dictated by some of the contingencies of the clinical trial. I think this represents a successful feasibility study of a promising new technology, and I eagerly await the 12-month freedom from atrial fibrillation results. Thank you.
This is Usha Tedrow from Brigham and Women's Hospital in Boston, and I'm providing the commentary on the pulsed AF study, the experience and acute outcomes of a novel pulsed field ablation system. First, a little context. Limitations of standard catheter ablation techniques include local recurrences, as well as complications such as pulmonary vein stenosis, phrenic nerve palsy, and atrioesophageal fistulae. Thermal ablation strategies depend on time-dependent conductive heating and cooling and ablate all tissue types indiscriminately. Pulsed field ablation, or irreversible electroporation, ablates non-thermally by creating microscopic pores in cell membranes resulting in cell death. Individual tissues have different threshold field strengths that induce necrosis, and cardiomyocytes happen to have a very low threshold for injury, making them an ideal target for PFA. In this study, they were evaluating the safety and efficacy of PFA for pulmonary vein isolation. The N was 14 patients, not 20 as planned, due to the COVID epidemic. They had 100% pulmonary vein isolation success, and there were 7.4 energy applications on 56 veins. There were no touch-up lesions required to be administered with another catheter, and 5 patients were even ablated with conscious sedation. There were no adverse events reported. It would be interesting to know more about the advantages of this particular catheter over other shapes and styles of PFA catheters that are in development. To summarize, the authors are to be congratulated for their excellent short-term results in terms of both feasibility and efficacy, and we anxiously await the clinical outcomes on the treated patients. Thank you very much.
On behalf of my colleagues, I'm pleased to be able to present our abstract on point-by-point pulse field ablation. The ablation system that we studied is manufactured by Affera, and these are the various disclosures for the various authors. Note that this is not an FDA-approved device, nor does it have CE mark. Here's the catheter itself. It's a 9mm lattice tip diameter catheter, a 7.5 French shaft, and you can see that the tip is deformable. There are 9 nodes on the surface, each of which contains a mini electrode as well as a surface thermocouple. Energy is delivered from the whole lattice tip, so the amount of catheter tip that interacts with tissue is typically much larger than with the standard catheter. There is saline irrigation from the center of the catheter, and each lesion is between 2.5 and 5 seconds in duration. And there's also an integrated mapping system. We used this catheter previously in our pure radiofrequency ablation study of 65 patients at 3 different centers, and these were the outcomes. Excellent RF application times and transpired ablation times in order to achieve these various endpoints. And importantly, on remapping at 3 months, you can see that the durability was quite good, both for PV isolation in the high 90%, as well as for the various linear lesions. Also importantly, this translated to excellent clinical outcomes. With the median duration of 270 days follow-up, the overall success was 94%. Now, one important problem with radiofrequency energy is, of course, the potential problem of damage to the esophagus. Now, we and others have shown that because of its tissue selectivity, pulse field ablation provides some advantages. Here you can see on this MR image, ablation of the atrial tissue with sparing of the adjacent esophageal tissue. So this lattice tip system was constructed so that not only can it deliver RF energy, but it can toggle to delivering PF energy. Notice that during RF applications, the temperature goes quite high, but during PF applications, there's minimal increase in the temperature. So here's a study that we conducted. It's a non-randomized first-in-human study where patients were enrolled at 3 European centers, 76 patients, either 55 paroxysmal or 21 persistent patients. The procedures were under general anesthesia, largely using a deflectable sheath. Intracardiac ultrasound was used in all the cases, as well as an esophageal temperature probe. The ablation strategy was PV isolation in all patients with linear lesions as desired per the operator preference. There were two cohorts. The RF-PF cohort included 40 patients where RF was used anteriorly and PF posteriorly, versus the remaining patients where PF was used throughout. Here's just an example. You see the tip of the ablation catheter, and this is in the left atrium adjacent to the esophagus. So during ablation, you can see how closely it's associated. Let's just go through a case. First, mapping. The lattice tip is maneuvered throughout the left atrium to render the atrial anatomy, as well as to simultaneously create a baseline voltage map. Now let's go through some lesions. Each of these green dots represents one lesion. So the catheter is manipulated to a location, then PF energy will be delivered from the catheter tip. And here you'll see in just a second, the energy being delivered right there. And that's the ablation lesion. Then it moves on. So again, each lesion is 2 to 3 seconds long. So these are all PF lesions posteriorly. And as we come around anteriorly, and you can see on this top-down view, we're a little bit more anterior, then we switch to RF energy. And here you see the big blush of heat as an RF lesion is being delivered. And then this continues on to finish anteriorly the RF lesions. What about the mitral annular lesion? Well, this is the approach that we ended up favoring. First, we take the lattice catheter, put it in the coronary sinus as deep as it goes, and then we deliver one PF application within the coronary sinus. Then the catheter is manipulated into the left atrium and is used to create a standard mitral isthmus line adjacent to that CS lesion that was placed. And here we see the testing during proximal CS pacing. The time from stim to the electrogram on this catheter is quite long. And similarly, when we pace from the lattice catheter, there's reversal of activation, so the CS proximal comes before distal. These are the patients that were enrolled. Again, 76 patients. You can see about 3/4 were paroxysmal and the remaining being persistent. And that was evenly split between the RF-PF and the PF-PF cohorts. Here's some examples of the cases. There's a baseline voltage map, as well as the lesions, PF posteriorly, RF anteriorly. Here's some pure PF cases. Here's during CS pacing after a mitral line, you can see that everything is blocked. Also, you see that the roof line is blocked. And here's an example where there was a box posterior lesion, all with PF. These are the procedural parameters. Again, you see excellent RF application times, as well as transpired ablation times. And here in light, you see the RF only cohort. And these are the previous study. And you can, again, quite comparable. So excellent transpired ablation times and other parameters. If we look from a safety perspective, major complications, there were no strokes, tamponades, phrenic nerve palsies, PV stenoses, or atrioesophageal fistula. There were some vascular complications. What about the esophagus? There were 2 instances where there was minor erythema noted, both in an RF-PF cohort. Why was there any esophageal abnormality? Well, it turns out this is the issue. Here's an example of one of the patients where the ablation catheter is placed in the left inferior pulmonary vein to deliver lesion anteriorly. And you can see during RF ablation, yes, there is heating anteriorly, but because of the size of the tip, there was also heating inferiorly and, importantly, posteriorly. So what we learned from this is that when we're in this situation where the catheter is touching posteriorly as well as anteriorly, simply use PF energy. What about brain MRIs? There were no strokes or TIAs. We did do brain MRI imaging in 51 patients at 1.2 days after the procedure, and you can see that there were some DWI positive, flare negative, and flare positive lesions that were seen. Note that when there was MRI positivity, the ACT was really low compared to when there was MRI was negative. So this is the final slide. What we found was that acute outcomes with the lattice tip catheter, they were highly efficient, a safe procedure for both PVI as well as linear lesions. There are a number of limitations. The 2 most important questions are how durable are these lesions and what are the long-term clinical outcomes? And this needs to be studied further. Thank you very much.
This is Dave Callans presenting the Dove commentary on the study, which was point-by-point ablation using pulse field ablation plus minus RF using the FHRS system. It's a multi-center prospective observational study. The FHRS system is a large surface area system for recording and delivery of both pulse field ablation and temperature-controlled RF. The applications were only 2.5 to 5 seconds in nature. The study looked at acute safety and acute efficacy. There were 76 patients, 55 with paroxysmal and 21 with persistent atrial fibrillation. There were no ablation-related complications in either group. In the pulse field group, all of the energy was delivered with pulse field ablation, and in the RF group, the posterior lesions were delivered with pulse field to avoid damage to the esophagus, and the anterior lesions were delivered with radiofrequency ablation. On endoscopy, which was performed in 60 patients, there were minor erythema lesions in the esophagus in 2 patients, both of whom were in the RF group. Brain MRI was performed in 51 patients, and there were diffuse and weighted imaging positivity in 8 patients. For acute efficacy, all patients had demonstrated PV isolation and block across linear lesions. This demonstrates a successful feasibility study of a promising new technology. The Affera catheter has been used in clinical trials before, but only for delivery of RF energy. So the new part of this is the pulse field ablation energy. We await the 12-month efficacy results, although the prior results, at least delivered with RF, suggest durable success. Thank you.
This is Dr. Usha Tedrow from Brigham and Women's Hospital in Boston, and I'm providing the commentary on point-by-point pulse field ablation plus or minus radiofrequency ablation to treat atrial fibrillation. A little context. Because it has small electrodes embedded in the spherical shell, the lattice catheter design can allow for larger lesion delivery without sacrificing detailed electrogram fidelity, which is a problem for larger tip electrodes. The catheter is irrigated, reducing the risk of char or coagulum formation during radiofrequency ablation. The catheter can also deliver non-thermal, pulsed field ablation lesions in a point-by-point fashion, potentially with less risk of collateral injury during ablation. In this study, patients were enrolled who had paroxysmal and persistent atrial fibrillation, and the ablation strategy includes pulmonary vein isolation and additional lines at the operator's discretion. In the group that was combined radiofrequency and pulsed field ablation, patients received radiofrequency ablation anteriorly and pulsed field ablation posteriorly. In the other group, comprised of 36 patients, they received pulsed field ablation both anteriorly and posteriorly. Let's discuss the complications briefly. 2 minor esophageal erythematous lesions were seen in the radiofrequency group, and Dr. Reddy in his discussion provides some explanation for the anatomic reasons why this may have occurred, with some contact of the lattice catheter posteriorly, even when the main portion of the catheter was localized anteriorly. In addition, an MRI was performed in 51 of the patients. It was performed at 1.2 plus or minus 0.6 days after the procedure. It's not mentioned what the distribution of groups was among the patients receiving an MRI, and it is not mentioned why some patients received an MRI and not others. Abnormalities were seen in 8 of 51 patients, or 15.6%. DWI with positive FLAIR images were seen in 5, and DWI with negative FLAIR images were seen in 3, which was a total of 5.9%, which might indicate a more recent ischemic insult. It's also mentioned that MRI findings were more common when the ACT levels were subtherapeutics during the procedure. In addition, and it's notable to mention that an uninterrupted DOAC trial that was recently published reported a 4% silent stroke rate in standard radiofrequency ablation patients. So this rate may be slightly higher, but not out of the range of expected. In summary, the lattice catheter can deliver effective lesions with both radiofrequency and pulsed field ablation. An advantage of pulsed field ablation may be less esophageal injury, and it will be interesting to see if the long-term durability and outcomes of the RF and PF lesions are different to determine if pulsed field only may be a reasonable strategy for this catheter. Thank you very much.
I would like to welcome everyone watching this virtual presentation, wherever you are. On behalf of my co-investigators, it is my pleasure to share with you the primary endpoint results of the UNTOUCHED study. My disclosures are listed on this slide. The subcutaneous implantable cardioverter defibrillator, or S-ICD as it is better known, was designed to provide protection from sudden cardiac death while reducing complications compared with transvenous leads. However, relatively high inappropriate shock rates, particularly for T-wave oversensing, have been reported with early S-ICD devices and implant techniques. The most common indication for ICD therapy is primary prevention with a reduced ejection fraction. Such patients have been underrepresented in prior S-ICD studies, which tend to enroll less sick patients. To date, no prospective study has evaluated outcomes with the S-ICD using contemporary devices and programming in a primary prevention population with left ventricular dysfunction. The hypothesis of the UNTOUCHED study is presented here. The UNTOUCHED study hypothesis is that the incidence of inappropriate shocks at 18 months in primary prevention low EF patients will be non-inferior to the rate in transvenous ICD patients observed in MADE-IT, high rate and long duration arms. UNTOUCHED is a global, multi-center, prospective, non-randomized trial. De novo implant patients were enrolled at 110 sites and were followed for 18 months. Devices were prescriptively programmed with the conditional zone set to 200 beats per minute and a shock zone of 250 beats per minute. Patients were enrolled if they had a primary indication for sudden cardiac death, an left ventricular ejection fraction of 35% or lower, no pacing indication, and if they passed the S-ICD screening vector test. The study's primary endpoint was an inappropriate shock-free rate at 18 months compared to a performance goal of 91.6%, which was derived from the inappropriate shock rate of 94.6% measured in ICD patients in MADE-RIT study arms B and C. UNTOUCHED secondary endpoints were the all-cause shock-free rate at 18 months with a performance goal of 85.8% and a system and procedure-related complication at 30 days. Of note, this latter endpoint was previously reported and published. Implants were attempted in 1,116 patients. We report endpoint analyses on the 1,111 patients who received devices. The characteristics of the patients are shown on this slide. Of note, the mean age was 56 years with an EF of 26% and 88% had heart failure. Most patients had ischemic etiology. Compared to other S-ICD studies, the untouched patient population is sicker with lower ejection fractions, more heart failure diagnoses, and a higher rate of ischemic etiology. However, the patient cohort is similar to that in landmark transvenous ICD studies, such as MADE-2, SCUD-HEFT, and MADE-RIT, except that they were a younger population, presumably due to the pacing indication exclusion criterion. The primary endpoint results are shown on this slide. The inappropriate shock-free rate is 95.9% at 18 months, with a 95% lower confidence limit of 94.8%. These results significantly exceed the performance goal of 91.6%. It is noteworthy that the inappropriate shock rate noted here is very similar to the 94.6% observed in MADE-RIT arms B and C. Multivariable predictor analysis shows that patients with a history of atrial fibrillation, non-ischemic etiology, and lower ejection fraction were more likely to experience inappropriate shocks. Procedural characteristics that predicted fewer shocks for the patients were implantation using the 3-incision technique and implanting devices with the SmartPass filter. This feature is the latest technology improvement intended to reduce the risk of inappropriate shocks. Subgroup analysis showed that the inappropriate shock rate over 18 months is only 2.9% in patients implanted with SmartPass technology with extracardiac oversensing markedly reduced. A comparison of inappropriate shock rates from S-ICD and transvenous trials is shown in this slide. The one-year inappropriate shock rates measured across the S-ICD studies have decreased substantially over time. The annual untouched inappropriate shock rate were found to be lower than those recorded in recent transvenous ICD studies using modern devices and programming strategies. Indeed, the one-year inappropriate shock rate for untouched is the lowest recorded to date for large multi-center trials. The secondary endpoint, the all-cause shock-free rate, is shown on this slide. The shock-free rate was 90.6%, significantly meeting its performance goal of 85.8%. Significant multivariable predictors of all-cause shocks are a history of atrial fibrillation and lower ejection fraction, as shown on the bottom panel of this slide. The untouched patient cohort experienced a total of 64 appropriate shocks in discrete episodes. The first and final success shock rates were 92.2% and 98.4% respectively. The one episode with a failed final shock converted spontaneously. Of note, this is very similar rates of success compared with transvenous studies. 7 subjects collectively experienced 58 episodes in 9 VT storm events. All of these storm events were successfully converted. The overall survival rate of this cohort was 94.9% at 18 months. Of the 53 deaths reported during the 18-month follow-up, 26 of which were classified to be of cardiac origin, including 3 arrhythmic deaths. These 3 deaths were due to pulseless electrical activity or asystole. In conclusion, the untouched study shows high S-ICD efficacy and safety with contemporary devices and programming despite the sickest cohort studied to date. The inappropriate shock rate, which was 3.1% at 1 year, is the lowest reported for the S-ICD and lower than many transvenous device studies using contemporary programming to reduce inappropriate shocks. I want to again thank all of the untouched investigators and sites who did the hard work on this study to make this presentation possible. Thank you.
This is Dave Callans with Dove commentary on Dr. Gould's. The subcutaneous ICD has evolved considerably since its IDE approval. There's been significant improvement in sensing to exclude inappropriate shocks, which was a yearly incidence of 13.1% in the IDE, and its extension to use in primary prevention in structural heart disease instead of electrical heart disease. This is the background for the untouched study, which had an important hypothesis that the S-ICD would be non-inferior to contemporary transvenous ICDs using mated RIT as the comparator in freedom from inappropriate. Dr. Gould presented registry data from over 1,100 patients with an ejection fraction of less than or equal to 35% and primary prevention indications for ICD. The population was similar in sickness to transvenous ICD trials, and there was an 18-month follow-up. The freedom from inappropriate shocks in 18-month follow-up was 95.9%, which surpassed the non-inferiority margin of 91.6%. The study was able to determine predictors of inappropriate shocks, which included history of atrial fibrillation, non-ischemic cardiomyopathy, and lower ejection fraction. There are also some important predictors of freedom from inappropriate shocks: the use of a 3-incision implant technique, and the implant of a Generation 3 device which had improved sensing algorithms. I think the untouched registry was a very important trial. It successfully demonstrated in a large population of patients a remarkable reduction in inappropriate shock incidence with improvement in technology and programming. Thank you.
This is Usha Tedrow from Brigham and Women's Hospital in Boston, and I'm providing the commentary on the untouched trial primary results. First, a little context. Untouched is an important study because it addresses concerns regarding inappropriate shocks with the subcutaneous ICD. Inappropriate shocks were 13.1% in early S-ICD studies. The SmartPass filter is essentially a specialized high-pass filter that can reduce the amplitude of lower frequency signals from the surface ECG, for example, from T waves. It reduced the annual rate of inappropriate shock to 4.3% in data published from 2018. It is not clear what proportion of the patients in Untouched had a device enabled with the specialized filtering, but it was a significant independent predictor of lower IAS burden in the study. A small commentary about the study design. This is a single-arm observational cohort, not a randomized trial as is customary for a non-inferiority trial. The comparison group is the mated RIT treatment arm B and C, which were used as a historical control for a derived performance goal. So it's important for us to think about how the mated RIT population might differ from the population in Untouched. The S-ICD patients in Untouched had no pacing indication and had to pass the ECG vector screening. Additionally, in mated RIT arms B and C, about half of the patients received a CRTD, perhaps indicating a sicker cohort. Here are some other differences between mated RIT and Untouched. As mentioned by Dr. Gold in his presentation, the mated RIT patients were about 10 years older. Additionally, there was a higher proportion of NYHA class 2 and 3 heart failure among the mated RIT patients. However, there were more patients with atrial fibrillation in the Untouched population, which was a risk factor for developing inappropriate shocks itself and should have biased towards the null. To summarize, Untouched showed that in a non-randomized cohort of patients that the S-ICD has a low inappropriate shock rate of 3.1%. A randomized trial would be ideal for comparing transvenous and S-ICD inappropriate shock rates to establish non-inferiority. Untouched additionally provides some important corroborating evidence that adding specialized high-pass filtering can further improve the inappropriate shock rate for the S-ICD. Thank you very much.
Thank you for joining the second of our late-breaking clinical trial sessions at HRS 2020 Science. Congratulations to all our presenters for a job well done, and many thanks to all the investigators and innovators for providing amazing technology and research that will continue to advance our field and improve patient care.